Hello, hello, everyone. How's everyone doing?
Good. How are you?
Good. This is going to be a good one tonight. Let me get all set up here. Hey, Steve.
Have you been good?
Hanging on by a thread. But I officially graduate from Drexel next Friday.
Congratulations.
Thank you.
You
And
felt
then I am traveling to Hawaii to go hang out with Sachi for a couple weeks, and then I come back and defend my dissertation, and I am done
if you
forever.
need help defending, you let me know. I'm here for you. Just physically, though.
Have you ever seen that meme that was like, when are we going to stop defending and start attacking? And I'm like, yeah, that's right. Hey, Alex, you want to try to share your slides real quick and make sure that everything is okay? And I'll just make sure that I have,
Sure.
give you sharing privileges here.
Yeah.
I'll make you a co-host. Awesome.
Work.
Yes, it looks good.
All right. I'll just stop sharing now and then you can
Yeah.
take it from there.
So I started, we're probably going to start moving because I'm going to lose my Drexel Zoom access. We're probably going to start moving the webinars to like a Google Meet. But I've been meeting with a developing team. Sashi and I have been meeting with this developing team the past couple weeks to start building the Atomic platform, the learning platform. And they use an AI note-taking system called Fathom. I don't know if anybody have ever used that before or any kind of AI note-taking system, but it is fantastic because I'm usually during every meeting trying to like frantically like take notes and scribble. And this AI system just listens to the whole conversation and just like summarizes the whole meeting and gives you all of the action items that you need to do, gives you a full transcript of the meeting and like a recording and everything. And it works really well. So I think I'm going to start using it for all of our meetings, and that way I could just send you guys the kind of like the highlights and notes right away. Has anyone in the chat, has anyone used any kind of like AI note-taking system? Maybe in class? Do you guys use that for class at all? Never heard of it. Yeah, Fathom's apparently free. It's like some kind of open source AI note taker. So I'll let you guys know how it goes when I start using it. Okay, we'll wait another minute or two and then we'll get started. How many people we got? About 65 people signed on. Awesome. Yeah, I've been talking to a lot of people about Notability lately, about all the functionalities. And I don't use Notability myself, but I know a lot of people do. And as we build this platform, we're trying to take some of the features of Notability and see if we can build it into the platform as well. Um, I think that actually it would be really cool if you can upload your class slides and notes into the platform along with our content and then use AI to kind of synthesize all of that material together to make you like custom quizzes, custom flashcards, or even talk to it like a chat bot in some kind of way. Notebook LM. Is Notebook LM kind of like Notability? Does it
Yeah.
function the same way? I'm writing these down. Rem note. Yeah, if you guys have any suggestions on like kind of AI functionalities you want to see, just let us know because we're currently building that right now. Okay, so we are going to get started. This is going to be a really good webinar because we have an expert with us. He is our content expert for all of anything cardiac and really thoracic or vascular, and has a lot of other skills as well. And I think you dabble in like some OB as well, right, Alex?
I dabble.
Dabble, truly dabble. But I want to introduce you guys to Alex Gorman. You might have heard him on our podcast. He has done a couple episodes there about cardiac anesthesiology and is also helping us build a lot of really cool content within the platform as well. Um, a little bit about his background. So he went to Boston College and also teaches at Boston College School of Nurse Anesthesia. He practices at a level one trauma center in Massachusetts and in New Hampshire, I believe. Or you began your practice in Massachusetts and now you practice in New Hampshire, and mostly doing cardiac anesthesia, vascular anesthesia, and also on the transplant team as well. So has tons and tons of experience. This is what he does day in and day out. Teaches regularly to residents, and we just love collaborating with him and working with him. So I'll let you take it from here, Alex. Thanks for coming.
Sure. Yeah, of course. Thank you. Yeah, just to kind of give you guys a quick idea of where I'm coming from. I've been a CRNA for 6 years, started at a level one kind of teaching hospital trauma center in Massachusetts for my first 2 years at a school, started doing cardiac there within the first month or so. Obviously sharing with residents and kind of it was a part-time job there, I would say. And I live in New Hampshire, and I moved to to a hospital closer to home that has it's a smaller hospital, but we have a very robust cardiac service. A lot of CRNA autonomy within that open heart program. We do a lot of hearts. We do a lot of really sick hearts. Kind of talk about that later. But right now, I'm probably doing about 95% of my time is in the heart room right now. So it's basically all I do. And I do maybe 5 weeks a year. I cover for a rural critical access hospital. I cover vacations for the CRNA group up there and do independent practice up there. And that's a lot more OB and blocks and a little pediatric and stuff like that. But my primary kind of gig right now is doing cardiac anesthesia with some vascular and thoracic thrown in there. The RIA kind of opened up with kind of where I wanted to head next, just to give me an idea whether, and for this entire presentation, interrupt me at any moment, anyone who wants to speak up. I am very happy to be taken on tangents, especially about cardiac stuff. We'll try to move through stuff quickly enough that we can have some time for some chatting about stuff. But I'll also keep the chat open and real look at the chat. So if people don't want to kind of yell out on the Zoom, then if you put in the chat, that would be great. But where are we in Ria? You can fill me into as far as this group. This is all people in anesthesia school right now, or are there CRNAs, or is it a mix, or?
We get a big mix. We have some RNs that are in the process of applying to school or have already gotten in and they're waiting to start the program. And then we have a lot of junior residents and some senior residents as well. So, and they're all over the country. Every time I ask, there's people from all over the place. So it's a nice community. So every time I give a talk like this, I try to touch on a couple things that will hit each one of those groups there. But yeah, definitely in the chat, if you want to say where you're at and where you're at in your journey and where you're living right now.
Yeah, I'm seeing some of that. So this slideshow is it's a presentation kind of modified that I give to the nurse anesthesia residents at Boston College, the juniors right before they start their cardiac rotation. So that's what this is kind of built around. I think anyone who's either done a cardiac rotation before, who's in thinking about CRNA school, who's maybe just starting CRNA school, you're still in the didactic, maybe this can kind of whet your appetite for what is going to be coming up in the future. But this presentation is kind of directed in that area. But like I said, I'm more than happy to kind of go off on tangents and talk about whatever you guys want. I've been doing cardiac um, pretty steadily for the last 6 years, and it's my passion, obviously, and I love to talk about it. So we'll go through kind of the pre-op, intra-op, post-op considerations for a basic cardiac case, the setup. There's a couple slides in there about TEE, about echocardiography. That's good to kind of learn about to give you a basic idea of that. A little bit of A-line, central line stuff, and then some kind of general stuff that I like to teach the people that I precept about more soft skills, just things to maybe make your rotations a little bit easier, whether it's cardiac or otherwise. So we'll kind of get started with that. And like I said, Ria, well, I don't know if I'll be able um to see the chat while I'm sharing my
I'll
screen.
I'll share any
I'm not sure,
questions
but yeah,
that
if
yeah.
if you want to kind of monitor that, and like I said, if
Yeah, yeah,
anyone
yeah.
has the guts to just pipe in and start talking, I'm more than happy to stop wherever I am and talk about whatever you guys want to talk about.
Yeah, yeah. I'm gonna share the slides right now in the chat for you guys, okay?
Let's do this so we can. All right. Everybody can see that, and we moved on to the outline page. We're all good there?
Yep, looks good.
All right. This is kind of the quick and kind of chapters, I guess, that we're going to be moving through as far as the case itself. And then there's going to be a couple other little extras thrown in there. But we're going to move through basically the considerations for a cardiac case. If you've never been in the OR before, that's fine. If you've done cardiac cases before, hopefully some of this will make a lot more sense with the little caveat that I've done cardiac at 4 hospitals now, including school. Every institution does things a little bit differently. So just because I go and talk about something that is done in the places that I've done, it may not necessarily mean that it's done the same way everywhere. So my kind of disclaimer is check with your preceptors, check with your facilities. They may not want you to do things the exact way that I do them. All right, pre-op. This is obviously not an all-inclusive list, but a couple really quick things that I like to talk about for pre-op, specifically for cardiac patients. First thing, the majority of cardiac cases are going to be coronary artery bypass grafting cases. So almost all of them should have a cath report, unless it's a absolute emergency that is coming from the cath lab, something like that. And a lot of valve cases, heart valve replacement cases, will also have a cath to see if they need any bypass grafts while we're replacing the valve. So you'll get really used to reading cath reports. I'm not going to get too far into the minutia on cath reports. The two things I do want to touch on are this LM and LM equivalent. So left main. Anyone that's been in the CVICU or a CRNA, we kind of understand what a left main occlusion is. Generally, anything over 90% is considered pretty severe. Anything over 95% is pretty critically severe left main stenosis. The reason that we care about that is that left main, if anyone can look on a chart of the coronary arteries, can see that left main feeds both the left anterior descending and the left circumflex. So it's a small little portion of the artery that feeds almost the entire left ventricle. So if you have a big blockage there, your entire left ventricle is in danger. I think that's probably not a new idea to a lot of people. The only other thing I want to touch on this is this left main equivalent. I don't know if anyone has ever heard of that, but basically what that means is that a proximal occlusion in the left anterior descending and left circumflex is basically the same thing as a left main occlusion. So a blockage of both of those arteries, the left anterior descending and the left circumflex, very close to the aorta, is the same thing as having a left main occlusion. So just because you look on a cath report and it says that the left main is clear or there's only a small amount of stenosis, you could still have that left main equivalent. So that's something to kind of look out for on these cath reports that can be a little bit tricky and really needs to be taken into consideration. Echo reports. Going to see a lot of these as well. The one thing that I want to stress with an echo, and that everybody from RN all the way through CRNA that I see do this wrong, is that your echo is more than your ejection fraction. A lot of the time, all you see is people saying, "Oh, they have they have great heart function. Their EF's 50%." They don't look into any valves. They don't ask about how the right ventricle is doing. Somebody could be severely, let's say they're in pericardial tamponade, and the only reason that their EF is so high is because their right side is collapsed and they're not getting any blood to their left ventricle, right? 50% of nothing is nothing. So they thinking beyond a EF and telling people, whether it's your preceptor or a surgeon, the entire echo report, what the left ventricular function is, what the right ventricular function is, and any valve issues, is a more complete way to both look at and kind of report an echo. Comorbidities, obviously, these can go into run the gamut. The main ones that concern us for cardiac: hypertension, diabetes, smoking. Those three are absolutely the highest risk factors for coronary artery disease that we see. Carotid disease and kidney disease, very important for cardiac surgery, for perfusion, for when they're on the patient's on the heart-lung machine. Somebody with carotid disease may need more, or kidney disease may need higher flows on the heart-lung machine to perfuse the brain and the kidneys. So if you're aware of that and you can clue in or kind of touch base with the perfusionist and the surgeon and decide on together on a goal for perfusion, for usually it's done by MAP, mean arterial pressure, when you're on the heart-lung machine. It's a good thing to know about either carotid disease or kidney disease.
Alex, we have a
And
quick question here.
oh yeah, of course.
Quick question in the chat. So, Jasmine is asking, as a CRNA, do you learn to read the cath images or do you just go off the report?
I do look at the cath images just because I'm kind of a nerd and they're cool. But generally, if you read the cath report, that's adequate. I try to read for both the echo and the cath report and any of my other imaging, X-rays, CT scans, any of that. I try not to just read the impression that the procedurist will put in at the very end, like the summary. I try to read through every section because there are absolutely things that are important to me that may not be important to the radiologist or the echo tech or whomever is dictating the report that could pop up there. So it's fine that you're not actually reading the echo or you're not actually reading the cath report, but just try to get in the in the headspace where you're responsible for every section of that report. You're not just reading the cliff notes.
I want to just say a quick note about really any kind of imaging note is that a lot of these radiologists read something not in context of the patient's clinical history and situation and what you're looking for. And sometimes, rarely, but sometimes the summary or impression is either wrong or missing some, like Alex said, some critical pieces of information that might be important to you, especially when looking at things like chest x-rays or CT scans of the airway, that kind of thing. Sometimes they just miss things. So it is a good idea to learn how to, at least get a rudimentary understanding of how to read these images as well. Just my 2 cents.
Absolutely. Setup. So this can be one of kind of weirdly the most stressful parts of your day as a nurse anesthesia resident, is trying to get that sweet spot of setting up where you're showing your preceptor and everyone that you work with that you're prepared, but you're also not wasteful. right? And I think anyone that's been through, there's either in anesthesia school or has been through anesthesia school, we have some preceptors that if you don't have absolutely everything for a simple gallbladder removal, you get yelled at, or you could be doing the most intense aortic aneurysm, and if you open up an extra bottle of saline or extra bag of saline, they'll start yelling at you that you're being wasteful. So you definitely have to check with your preceptors on this. For cardiac cases, I think it's safe to err on the side of being overprepared a little bit. There's nothing that well, there's a lot of things, but there's one of the things that kind of bothers me sometimes is when a resident that I'm precepting seems a little unprepared or underprepared. I think it's always better to err on the side of over-preparedness. Again, kind of balancing that preparation with wastefulness. I think a good way to toe that line, whether it's for cardiac or anything else, is that you can have a lot of stuff in the operating room, but you don't necessarily need to open it. So that if you don't use it, you can always return it and the patient won't get charged and it's not necessarily wasteful, but you're also showing that you thought of the potential need for certain drugs or certain other equipment. Huge thing with cardiac surgery, heparin is an ACLS drug in heart surgery. So what I mean by that is that at any moment from when the patient comes into the room to when they leave the room for cardiac surgery is that patient is a potential for crashing, for having cardiovascular collapse, and being needed to be immediately kind of emergently placed on the heart-lung bypass machine. Before every case, when you're drawing up your induction medications, your paralytics, you draw up heparin as well. Usually 30,000 units, which is about the dose that we use to go onto the cardiac bypass machine. That is because if during induction or during sternotomy or at any other time during the case, there is an emergency and the patient crashes, the last thing you want to do, and I've been in this situation before, is be drawing up a couple vials of heparin as the surgeon is trying to cannulate to go on bypass. You're going to use the heparin anyway, draw it up before the case, leave it on the back table, and always have that ready because it will, if you do a lot of cardiac a couple times in your career, you'll be very, very happy that you have that ready. Pre-induction. So generally this changes a lot from facility to facility. Some places I've worked, we put in A lines and pre-ops. Where I currently work, we bring the patient into the room, hook them up to monitors, give them some sedation medication, and put it in the operating room. So I won't go too much into that. That's kind of a cultural thing, but just obviously touch base with your preceptors. There's not a huge difference about where you do it. I just kind of stick to the culture as far as that goes. As far as arterial line tips, we're not going to get too far into the weeds on this. I think through Atomic, we were planning on doing a couple videos or some podcast content, a little bit of content on this. Suffice to say, you will not get good at A lines or arterial lines until you've done hundreds, probably. I mean, at this point in my career, I've done cardiac and vascular and transplant. I've done multiple A lines a day for years and years. I've done thousands, and I still have ones that just absolutely frustrate me. And they just really whoop me sometimes. So this, I think, is the hardest skill in anesthesia, or at least the most frustrating skill in anesthesia. So there's a lot of good content out there, and we hope to probably be releasing some more good content to help people with that. But if you're not great at them and you're just starting out, even if you're a new CRNA a couple years out, you just have to keep doing them. Big IV before you go to sleep. Obviously we want some IV access. That's kind of makes sense. As far as induction goes, not going to get too far into pathologies here, but each specific pathology in cardiac anesthesia has different goals. If you're in the CVICU or in anesthesia school, obviously you're probably getting these beaten into you as far as your hemodynamic goals for aortic stenosis versus regurgitant pathologies versus tamponade. Knowing them and knowing how to fulfill those goals. It's not so much the medications that you use, it's how you use them and how you balance out the negative side effects of them. If I give some, I'm not one of these people that say you can't give propofol to X pathology. You can give propofol to anybody. It just depends on the dose, the timing, and how you're going to
Alexa,
manage
turn on
the
dining light.
the things that I the things that I know propofol is going to do. So I know it's going to dilate someone's peripheral vasculature. So I can pre-treat for that with something that's going to offset that rather than wait for the inevitable dump in the blood pressure and then kind of be behind the eight ball. So knowing your drugs, knowing your pathology, obviously super important. Kind of went over that. Anybody have anything that they want to touch on so far? Questions?
I had put in the chat when you said drop the heparin, and I said, but don't drop the protamine. Can you just explain real quick for people that might not know why I said that?
Yeah, absolutely. So protamine is the reversal agent for heparin. When the patient is on the heart-lung bypass machine, just the simple act of the blood running through this foreign circulature is very prothrombotic. So if the blood wasn't anticoagulated. Basically, as soon as we put somebody on the heart-lung bypass machine, the patient would have this weird inflammatory response, throw a bunch of clots, and pretty much immediately die. So we have to use an anticoagulant to keep those clots from forming. So heparin is the one that we use. The main reason we use heparin is because we can use something protamine to reverse it at the end of the case, to turn off that anticoagulation. The problem is that there are instances in the literature and in case reports in which that reversal is given, the protamine is given while the patient is still on the heart-lung bypass machine. So, you're an hour into the procedure, the surgeon's working, they're on the heart-lung bypass machine. Somebody turns around, grabs a bottle of what they think is maybe aminocaproic acid, draw it up, give it. It ends up being protamine, and the entire heart-lung bypass circuit clots off. It's not able to keep that blood moving, and you're not able to get a new circuit in there in time, and the patient dies. So basically, the general rule is that you do not draw up the protamine, or you sometimes even have it near you until the surgeon is ready to, the surgeon asks for it and the patient is off bypass and we're ready to decannulate and come off pump. So that's just one of these things that you have to be, there are some medical or medication errors that no medication error is good, but there are some that you can get away with. You give Zofran instead of Decadron, something like that. This is one that will just immediately kill your patient. So we just are very protective in the heart room, especially if with somebody that's getting precepted, resonance, things like that, to just have the protamine far away and don't even introduce the possibility of a medication error involving protamine, because that's a serious one. Anyone else have any questions?
There's one more question that said, where does the CRNA collaborate with the perfusionist in terms of hemodynamics?
So basically, the main interaction of when we're working with perfusionists is going on pump and coming off pump. Going on pump kind of depends on, I think there's a slide on it later, about how there's two basic different methods of going on pump. The first is that the perfusionist primes their entire circuit with crystalloid and goes on pump. The other is something called wrapping. So it's retrograde autologous priming. Basically, they fill the perfusion circuit with the patient's own blood, and that prevents having to use a couple liters of crystalloid to prime the circuit. The only negative with that is that you're draining basically half the patient's blood volume before they're on bypass. So that can obviously cause some hemodynamic excitement. So we try to kind of collaborate during those moments, but the big moments are coming off pump. So the heart-lung machine is kind of weaned down and turned off, but all the cannulas are still in. And so I'll look at the TEE, I'll look at the volume status in the ventricle and in both the right and left ventricle. I'll look at the blood pressure and talk to the perfusionist about the perfusionist can still give some volume, some blood from their pump, but we don't want to give too much and cause a hypertensive issue, especially with a fresh heart that hasn't been given protamine yet. That's going to bleed a lot. So that's probably the most kind of careful interaction. I'm going to be giving my hemodynamic drugs, usually a vasopressor or something, just to get the patient off pump, and while simultaneously looking at the TE and asking perfusion for a little bit of volume at the moments that I think I need it. Whether I say, hey, can I have 100 of blood? Give me 200 of blood? And they can transfuse that basically directly into the aorta. We'll kind of move forward here, and feel free to throw stuff into the chat, as we said. So after induction is generally when we do lines. Every cardiac patient is probably the only one of the few procedures anymore that every patient gets a central line for. We put a big central line in the neck. Usually it's a volume line, not just a triple lumen. It's usually something bigger, like a 8 or 9 French. And through that, depending on the culture and the case, we can put a pulmonary artery catheter. Some facilities use a PA catheter for every single heart case. Some use it for very, very few. Some it's surgeon dependent. With the rise of the use of TEE, I lean much harder on my TEE than a PA catheter now. But when the patient goes to the CVICU, a lot of times it's nice to have a PA catheter because they won't necessarily have that TEE in to check volume status and things like that. As far as insertion of central lines, especially for students, order of importance, this is a big thing. Lines have to be sterile. Lines have to be safe. Those are the two most important things. The next things that they end up in the right place and that you do it relatively efficiently are never as important as central lines going in sterilely. The neck is right near the sternal incision. There have been instances of central lines that have become infected, tracking to a sternum in a heart patient, and causing obviously huge issues, and safe. So basically you can't dilate the carotid artery or something like that. So this is something we stress really highly with all of our all the people that we precept at our heart program, is that central lines need to be sterile and they need to be safe. The other things don't really matter if those first two goals aren't met. Videos, both for A lines and for central lines. I think the plan is for Atomic to release a little bit of content on this as well. Some videos kind of walking you through the step-by-step with central lines, using ultrasound for central lines. One thing that I do like to stress is a lot of the time it's the non-central line insertion things that can be the hardest for residents. Things like putting on a sterile gown and gloves. The ICU nurses that are on this call probably have never done that. If you go to CRNA school, you get maybe 1 or 2 lessons in a lab, and then in front of a room of 10 people who are all staring at you, you have to put on a gown and glove for the first time sterilely, and you contaminate yourself and you have to get new stuff, and it's just a very stressful situation. If you can watch some videos, a lot of like surgical tech programs will release videos on how to gown and glove. That can be a great stress reliever if you're able to just do that and move on and focus on the actual central line. And knowing how to suture is really important. I've had several instances where I had a preceptee put in a beautiful central line. It was so good, it was so perfect, and then they couldn't really suture, and I had to scrub in and kind of finish the suturing for them. So if you're able to do it start to finish, that's great. During this time, post-induction, there's very little stimulation. These people have not had their coronary artery disease or their valve disease fixed yet. And if you don't pay attention and you get tunnel vision focusing on the central line, you can let the patient get hypotensive, or bad things can happen. So every 10 seconds, I like to teach people, every time you take a breath, kind of look up at the monitor really quick. It's like a good way just to kind of keep in your head. Every 10 seconds, look up at the monitor, make sure hemodynamically the patient is doing well, and don't get tunnel vision.
We have another question in the chat here.
Yeah.
So, Matt asked, do you manage ECMO or assist with that on patients that can't be weaned from the bypass?
So if they can't be weaned from bypass, we do, we're responsible for that patient until we leave the OR. So definitely, if we can't get a patient off the heart-lung machine, if we can't wean them off bypass and they have to transition to ECMO, we will still be taking care of that patient. A lot of the time, even though they're on ECMO, they'll still need some vasopressor support, things like that, and we will still be in charge of that. We also still run some moderate ventilation, even when they're on ECMO, just to keep the shunt to a minimum and keep any major north-south syndrome to a minimum. So we do kind of manage that. Once we drop that patient off in the ICU, then that would be managed by either the ECMO nurse or the perfusionist that's in the ICU. But we are definitely involved with kind of getting them out the door and to the ICU. We're also involved sometimes if a patient comes in to the cath lab, crashing in the cath lab from an MI, and they're kind of transitioning from an emergent PCI to maybe crashing onto ECMO. A lot of the times the cardiac CRNAs, if we're free, will go down, help get an airway in, help put some lines in, things like that, while all the providers, the proceduralists are busy getting the lines in for ECMO. So we'll be involved in some of that as well, kind of off-site ECMO stuff. Prep. So this is while the patient is being prepped. The only thing I'll say about this time, it takes a little while. Use this time wisely. You set up like a bird cage over the patient, give your antibiotics, organize all your stuff. And this is when generally you do your first TEE. So kind of the purpose of this slide is just to say there are these downtimes kind of in a cardiac case after lines and everything. You get a couple minutes to while they're prepping, use the time wisely. TEE, not going to get too into the weeds on TEE. I love doing TEE. I love being involved with it, but it is a very, very niche thing. This is just to give you kind of a very, very brief, especially if you're heading into a cardiac rotation, being able to just talk relatively intelligently about TE is a great way to kind of foster some conversations with either the physician anesthesiologist or the CRNAs, because usually most people that are in the heart room a lot and do a lot of TE, we're kind of nerds about this stuff, and we're more than happy to chat about it, and it makes our day if we have a student that likes to chat about it too. Basic TEE view, mid-esophageal four-chamber. I don't think, can you see my pointer there on the screen or no? You can? Okay.
Yes, we can. Mhm.
Okay, great. So top of the ultrasound is always called the near field. Down at the bottom is the far field. In most TEE views, the near field, the chamber in the near field is going to be the left atrium. So that's one way that you can kind of orient yourself. If you know that this chamber in the near field is the left atrium, then kind of by definition, you know that this is the left ventricle, the right ventricle next to it, and the right atrium over here. So that's just a good little tip to kind of orient yourself. Aortic valve, again, in both of these views, both here and here, the left atrium is in the near field at the top. The short axis view of the aortic valve, you can see the tri-leaflets. There's a little black dot right here. That's the left main coming right off the left coronary cusp. It's kind of cool. And then over here, this is a more of a long axis view of the entire left atrium, or sorry, left ventricle, the aortic valve opening kind of in the long axis next to the mitral valve, with a little piece of the right ventricular outflow tract down here. Mitral valve, this view has some color thrown on it. So you can see this would be mitral valve regurgitation. You can see that when the valve is closed, you're still getting some flow along the left atrial wall here and up there. And this is a transgastric short axis view of the left ventricle, just a view of how the ventricle is working. And even if you've never seen any echo before in your life, and you look at this one on the left and you see what's happening over there, and then you look at this one on the right over here, you can see that maybe this left ventricle over here is not quite doing as well as this one over here. One on the left, EF of 50, 55%, squeezing well, moving all in the circles, all coming together. This one over here, this area right here, which is the lateral and anterior wall, are moving a little bit. And then you can see this part of the donut, the septal inferior wall is just, it's kind of moving around, but it's not thickening. It's not doing much, EF of 15%. So kind of a heart that's a little bit sad. Left atrium is in the near field for TEE when in doubt. We're looking for thickening of, not necessarily movement. Here, you can see that this portion of the heart is kind of like jiggling, but it's not getting thicker and thinner like this section over here. That's what I mean by you're looking for thickening and not necessarily just movement. And for the majority of your time in the heart room, this is a qualitative assessment. You don't necessarily need to be able to shoot a valve gradient through an aortic valve, but you should be able to look at a left ventricle at the end of your heart rotation and be like, that looks good, that looks bad, that looks like there's some regurgitation, that looks like it's volume, it has enough volume, that one doesn't. If you can get to that point, that's a very, very helpful thing for both TEE and for transthoracic echo.
We have quite a few questions in the chat now.
Let
I'll ask.
me see. Let me see if I can get to them.
Yeah.
What does crashing on induction look like when you have to start them on bypass stat? So basically, it's just that people who are sick enough or who hemodynamically fail on induction, if they have severe cardiac disease, it's not quite the same as somebody getting hypotensive during a gallbladder surgery. When they crash pretty dramatically, and sometimes it's kind of the usual ACLS isn't enough to get them back. So the best way you would be for patients that are their pathology is critical. We usually have the surgeon in the room with us when we go to sleep. And that way, if there's an issue, it's basically like crashing somebody onto ECMO. We'll do our normal ACLS stuff, CPR, while they place cannulas in the groins and crash right onto the bypass machine. There's a perfusionist there, and we can usually get them onto bypass relatively quickly. ACT tags in my institution, perfusionists run those. Yes, Ria made an excellent point. I have a cardiac lecture that's more of geared towards seniors in CRNA school. That's a board review, and we do a lot more on TE because TE is now on the CRNA board exams. 6 years ago, when I took my board exam, I had a relatively complex TE question. So it is definitely on there. So you do not have to take any. So the echo codes are for billing purposes, and we won't get too far into the weeds as far as politics go. But as of right now, they are only open to physicians. So the certifying board for TEE does not allow anyone besides physicians to take that exam to be allowed to bill. I have privileges at my hospital to do and interpret TEE, so I cannot bill for that, but that is within my scope to do. Hopefully that makes sense. I know that there are workshops for TE. I believe John Shields has one at Mid-Tennessee. As far as kind of a whole workshop just for cardiac, everywhere I've been, it's all been on the job kind of training. So you start off as a CRNA, you're interested in the heart team, and then maybe you'll get a month of orientation with the cardiac CRNAs on the heart team. As far as buying a point of care ultrasound, I never have, but I've never found it necessary. I get everything I have at work. But if you are working somewhere that is a little more rural or something like that, that might be something that might be, the new butterflies and things like that. It's definitely opened the door to a more mobile, kind of individual purchase, which is nice. All right. I'll try to move through this kind of relatively quickly, so we have time for anything else. Sternotomy, super, super stimulating. So blood pressure control, opioids, esmolol, inhaled anesthetic. You just generally don't with the sternum is very, very vascular. So as soon as they cut it open, if the blood pressure is 160, there's going to be a lot of bleeding. So you want to kind of limit that as much as we can. When the surgeon does the sternotomy, they use a saw. It's basically like kind of like a jigsaw, if anyone has tools at home. And really important that that anesthesia turns off the ventilator so that the lungs collapse, so that the surgeon doesn't cut through the lungs when they're doing this. Some surgeons are really, really good about asking, especially in teaching hospitals. Some hospitals, like where I work, where there's four CRNAs that do all their cases, they just pick up the saw and zip, and we have to be paying attention. So hopefully your preceptors will be helping you with that, so we don't run into any problems. Lima, left internal mammary artery. This is one of the vessels that is used for the bypass to the LAD. You can kind of see that on the right side. The Lima is taken off the inner wall of the chest and then bypass down to the left anterior descending. It's fixed off of the left subclavian, so it's a really, really good vessel. Generally, patency rates for the Lima are 95%, 90% after 10 years, whereas for vein grafts, it's much, much lower, around 50%. So it's a really, really good bypass, and that's why they use it both just because of where it sits, but also they bypass the most important vessel, arguably the left anterior descending with it. During the part of the procedure where the surgeon is harvesting that Lima, it's a little bit of a downtime. Organize, get to know how your patient's going to respond to medications, a little bit of neo, a little bit of fluid, see how their blood pressure responds. And as the surgeon stops or kind of finalizes the Lima harvest, you're going to give your dose of heparin, and check an ACT, generally ACT above 450 seconds to go on to bypass, usually a little bit more. And they're going to cannulate. Very important part of cardiac surgery, putting in the aortic and venous cannulas, especially the aortic cannula. The reason it's so important is because the surgeon is going to cut through the layers of the aorta to be able to put this tube into the aorta. If the patient's blood pressure is too high when they do that and they expose those layers of the inside of the aorta, you can basically have cause an aortic dissection. The blood can push through those layers that are now exposed and cause a dissection. So you need the blood pressure usually under 90 systolic. Different ways to do that. Nitroglycerin, inhaled anesthetic, propofol, sometimes even just raising the head of the table a little bit and just positionally that'll get the blood pressure to drop enough that the surgeon can safely cannulate the aorta. But that's a really, really important part of the procedure, is being able to get that blood pressure down at the right moment. Venous cannula goes in through the right atrial appendage into the vena cava. There's always other sites that can be cannulated, groins, innominate, or axillary arteries, but the aorta and venous are the most common. You can kind of see here, it's kind of a busy picture, but there's a cross clamp on the aorta, aortic cannula through here to perfuse the body, venous cannula coming in through this atrial appendage, and then into the IVC. So bypass, we did talk about wrapping versus crystalloid to prime the pump already. During this portion, anesthesia going to be responsible for any drip, sometimes a little bit of a vasopressor or insulin, and then shut off the vent, silence the monitor. The patient will have a flat pulsatile tracing because the perfusion pump is not pulsatile. It's a constant stream of perfusion, so it will just have a map, and the surgeon will clamp the aorta, give cardioplegia to stop the heart, and cool the patient depending on the procedure to different levels of temperature depending on the procedure, generally around 32 degrees for a simple CABG. Our job is to make sure that the patient's making urine, which will indicate good kidney function. Give insulin to make sure that the blood glucose levels don't get too high. And organize, because the next step is probably the most important, which is coming off bypass. Separating from bypass, cross clamp was going to come off. The heart, a lot of the time, will start beating on its own. Sometimes we'll need a couple internal defibrillations to get started. The surgeon, in almost all instances, is going to put in some pacing wires, some chest tubes hooked up to a temporary external pacemaker. Anesthesia is going to start ventilating. I say be careful there because that lima that we talked about, that mammary artery that's sewn on to the left anterior descending, usually kind of lies right over the deflated left lung. So if when you start ventilating, you squeeze the bag as hard as you can to open up the lungs, there have absolutely been cases, and I've been in the same hospital as some of these happen, where the lima is basically ripped off of the LAD. The suture line is ripped off by ventilating too hard. And it's a really good way to make surgeons really, really unhappy with you to do that. Starting some drips, obviously, depending on the patient condition, vasopressors, inotropes. And we do a primary TE, make sure that the heart's squeezing well. If not, add a little bit of inotrope. We check the valves, make sure they're working well, and we check for any air that has gotten to the heart from any one of those many cannulation sites that we saw. Bypass is slowly turned down, and the patient's own function picks up, and hopefully they wean off bypass. If not, they may need a little bit more volume, a little bit more drug, and we kind of look at the TE and weigh all those things as to what the patient needs to get off bypass safely. Post bypass, we already talked about the protamine, and when to use it and when to be careful with it, especially mixing it. Generally do a blood gas, maybe a TAG. We give back some salvaged blood that is spun down by the perfusionist, so all the blood loss during the case isn't necessarily wasted. And this is just a portion of the case where the every cardiac patient is usually just kind of labile. Blood pressure goes up, goes down, not necessarily with a reason, and you just have to be really, really vigilant with how you treat it. And we're going to organize because we need to get out of the room here in a minute. Questions before we move any further with this? Either yell at me or through the chat.
We've just been kind of chit-chatting in the chat about various
Okay.
topics.
All right. So you've been in there. Nice.
Yeah. I think we're good. We're caught up. But if
Nice.
anybody wants to shout out any questions, definitely take this opportunity.
I did have a question.
Yeah,
So
absolutely.
you were mentioning giving protamine after getting off of bypass. I worked in CVICU and I would routinely see like Amicar hanging. Is that still something you would hang after giving the protamine to reverse them?
Yep. So the Amicar is not necessarily for reversal of the heparin. It's kind of so Amicar is basically the same as TXA. It's an antifibrinolytic. So that isn't going to make somebody's blood clot. It will just keep the clots that they form themselves from breaking down as quickly. So at my hospital right now, we use Amicar for all of our aorta and valve cases. We don't use it for straightforward CABGs. And it's not a very strong drug. It just gives a little bit of extra help. So we actually give Amicar at the beginning of the case and then again at the end of the case. So we literally give heparin and give Amicar within 5 minutes of each other. So the Amicard doesn't necessarily affect the anticoagulation of the heparin. It's more for after the protamine turns the heparin completely off, there's just other coagulopathies that are going to exist after a cardiac surgery. And the Amicar helps with a little bit of that, retaining those clots without being prothrombotic. Because remember, these people just have blockages in their arteries. More than likely, we don't want to shift too far in the other direction and make things too thrombotic and cause more blockages or anything like that. So Amicar is very nice because it's a gentle drug that isn't going to necessarily cause problems, but will give a little bit of treat a coagulopathy a little bit. Does
Thank
that
you
make
so much.
sense?
Yeah, that made so much sense. That I appreciate that. Thank you.
Yeah, of course. Go back. Yes, we block at the end. We block unless somebody, one of our hearts is bleeding excessively. We block all of our hearts. I do PEX 1, PEX 2 blocks, and some people do serratus blocks. We do bring our patients down on Precedex. We'll probably talk about in a little bit. TXA, absolutely. The ortho bros love TXA, but that's probably ortho and the OB providers have gotten really, really into TXA.
I have a question regarding weaning off the bypass.
Yeah.
At what point would you kind of suspect that maybe they're not going to be able to be weaned off and maybe need like balloon pump or impeller or more assist devices? And then how would
Yeah.
you go about that?
Generally, it's very rare that we go into a case and think everything's going to be great, and then they come out afterwards needing a device, whether it's ECMO or an Impella. Generally, these are the people that are coming to the case and they're already really, really sick, and whether their function is really bad, their right ventricle is really bad, and we're already suspicious of them needing a little bit of help getting off. We have transitioned a lot into more devices kind of earlier rather than a lot of drugs. So on a patient that maybe 5 years ago we would have brought down to the ICU on, 8 of epi and 12 of norepi and a little bit of vaso. Now we're just putting an Impella in the OR. We're bringing them down on 1 of epi and a couple of norepi, and that device has many fewer negative implications than these high dose inotropes and vasopressors. So there are cases where you're kind of surprised by that, by the, I guess, inability to wean off bypass effectively. And then it's just kind of a discussion between the surgeon and us. Hey, we've pushed epi, we're on an epi drip, we gave him some milrinone. This is the issue, right? Because if the left ventricle isn't working, that might be something that we can just treat with some inotrope. Whereas if it's the right ventricle that's a problem, an Impella is not necessarily going to help that. So it'll depend a lot on the actual problem. If it's just severe vasoplegia, those are all going to react differently or necessitate different either treatments or devices to solve those problems. So that is really just a discussion with the surgeon. Sometimes you end up having to go back on bypass for a little bit to get the Impella into the room and set up, put an Impella, try to come off again with some help from the Impella, things like that. But it's generally not a decision that we need to make in the course of 1 minute or 2 minutes. We try some things and we have enough time with the backup from the perfusion pump to try a couple things and see how the heart's reacting to each one of those interventions. Does that answer your question?
Yeah, that makes sense. Thank you. Yep,
Okay.
absolutely.
Okay. The vents are not part of the cannulas. I didn't really want to get too much into all the different vents that we put in, but suffice to say, there are besides the aortic and venous cannulas, there's cardioplegic cannulas, there's retrograde cannulas, there's LV vents, there's all these different things that are kind of jammed in there to do different things. I just not necessarily, I don't want to waste too much of our time getting into the minutia. We don't use methadone on our hearts. I know some people do. We use a lot of ketamine. We do not use a lot of opioid on our hearts, and we use blocks. Yes, definitely BIS. We do use BIS, and it's a great way to, especially when they're on bypass, to help a second set of eyes. For those who don't know, so since the lungs aren't ventilating on bypass, we can't provide volatile anesthetic. So the bypass pump, the perfusionist, actually has a anesthesia volatile anesthetic canister that they can just turn on, and it goes right through the bypass circuit into the blood. They are sometimes better about that than others. BIS has more often than not shown me that you'll have a BIS of 1 or something while on bypass. So more often than not, the perfusionists give a little bit too much volatile anesthetic, and we can say, hey, are you having trouble with your blood pressure? You could probably turn down that volatile a little bit. Their BIS is 4. But yeah. And we do all our hearts with Precedex, and we start that basically when we're closing the sternum. I know some other people are chatting in there, which is great. Yeah, we always give secret drugs in the elevator to make ourselves look good. Directly as a cardiac CRNA, usually not. I was lucky. I was in the right time, right place, and I had known from my training that I wanted to do cardiac anesthesia, and I was at a training site where I did like 60 hearts. So I had a lot of experience, and so that made that transition a lot faster from when I got hired to when I was able to start doing hearts like within a month. Generally not like that. Generally we like for our team, generally it's a couple years before we'll have a new grad, and then we'll train them up, but we never say never. Yes, I would still use Precedex if my patient is bradycardic in a cardiac case, because they all have epicardial leads and a pacemaker, so I can just turn up their heart rate to whatever I want. It's great. It's like cheating. Transfer. I think somebody mentioned it, bringing down your patient with all kinds of lines, all tangled and a mess. We try not to do that, but obviously it's sometimes easier said than done. A great way to prevent that is if you don't like need it on the patient, like BIS monitor anymore, things like that, take it off, get down to bare bones. You just want your pump, your IV, your monitor, and your patient. Always bring some emergency drugs with you. I always bring a vasopressor, some epi, and something to turn down the blood pressure, whether it's nitro, clofidipine, propofol, something like that. And again, you're driving a bed and you're ambu bagging the patient. You still have to keep a very, very close eye on the blood pressure and make sure your patient's safe. And report to the ICU. Obviously, that's going to change facility to facility. Other types of cases, valve cases, aortic and mitral valves are by far the majority of valve replacements that we do. In my facility, we do a lot of aorta work. So ascending aortas. Actually, I was a little nervous today. I had a type A dissection come in kind of late in the morning. Which are really long cases. Usually they're like 8 or 10 hours. So I was a little bit concerned that I was going to make it to this this lecture, but it worked out really, really well. Those are cases that we do sometimes. Resternotomies are a little bit more complex because the lungs and the pericardium and the heart can kind of get adhered to the inside of the thorax. Dissections, what I just mentioned, and interventional cases, TAVRs, MitraClips. That's a huge area in which anesthesia is starting to become more and more involved, and more cases are going to the cath lab for valve replacements and things like that. And vascular cases, a lot of times the cardiac team is responsible for vascular cases as well, like it is in my facility. Quickly want to talk about soft skills. through Atomic Anesthesia, we did a podcast, Rhea and I, about preparing for your cardiac anesthesia rotation. So if you haven't listened to that, if you want more information, I think we covered this area especially really, really well. These are like the free things that whether you're shadowing, you're a ICU RN that's shadowing, whether you're a preceptor, whether you're a new CRNA, you want to get on the heart team, something like that. Just things like, and I know it sounds silly, but you would be shocked at the amount of people in CRNA school trying to get into CRNA school that don't have the ability to show up place on time, be prepared to seek criticism, not just take criticism, but actually seek it out. And just generally being like a nice person. This slide will get you like halfway to your goals, and then you're gonna have to work really, 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 really hard for the other half. But just being able to get these soft skills and get people on your side and seek criticism is a super, super important thing. I'm not going to go over all these. I know Rhea sent out the slides, but just reviewing some of these. If you are a CVICU nurse that has a CRNA school interview, as soon as they see that you're a CVICU nurse, all this is going to be on their radar. Or if you are going to be starting a cardiac rotation within the next couple months, something like that. These are all really, really good things to kind of work through. Medications. Like I said, I'm not going to get too far into this, but look at the slide and brush up on these. And a couple other things that it would probably be good to go over, going over blood products, going over thromboelastography and PA catheter waveforms and values. I know we kind of moved through some of that. I'm trying to hit the questions and kind of move through this at the same time. Does anybody have any questions? Anything that I can answer right now?
I have a question.
Yeah.
Hi, how are you?
Hi.
So I just finished my cardiac rotation, and I came back from an away site and asked to join a few cardiac cases just to see how they do things differently. So I was always under the impression that every bypass machine has a vaporizer so that when they take over, they can anesthetize a patient. But the outside rotation that I was at, they actually said that they didn't have vaporizers in
Yep.
the bypass machine. And that specific attending didn't want to use a biz or a sed line. So I was just concerned as far as like awareness. Like, is there other indications that you would use if you were in that situation?
Yeah. So in that case, anesthesia was running just a propofol infusion while they
Yes,
were
I
on.
I hung up the propofol drip, but
Yeah.
I hung it higher than I guess I normally would have because I was just nervous in that
Yeah.
case.
So with even though the patient isn't pulsatile and their heart isn't beating, they will still have a sympathetic response. And so if their MAP did climb to weirdly high levels, that would probably be the only indicator that I can think of that there would be some awareness. That's not necessarily something that I would want to rely on. So I would probably be in your camp where if we don't have that number on a vaporizer of a Mac or at least something that we know is 95% assured to remove awareness, along with not having a BIS and not having the vital signs that we would normally have on a lap chole, right? It's you could see the rise in blood pressure, in heart rate, things like that, but we lose a lot of those things. I probably would be in the same camp as you, where I wouldn't necessarily feel comfortable relying on one variable, just the map, to give me an idea of the level of anesthesia. And I would probably do what you did and just err on the higher side. That was probably the right call.
Thank you.
Yeah. Anybody else have any other questions?
Jasmine had asked what you considered first line pressors in your cases.
Depends. Depends on your that the answer to all my residents hate it because whenever they ask me a question, I say it depends. Because it really does, right? So that would depend entirely on the pathology that I found most concerning for that particular patient. A patient with a tight left main, or aortic stenosis might have a completely different first line pressor than a patient with pulmonary hypertension, secondary to mitral regurgitation, and maybe like a dilated right ventricle. For aortic stenosis, my first line vasopressor is almost always phenylephrine. I want to keep the heart rate a little bit lower. I want to give perfusion because they have a big, thick ventricle and they need perfusion. They need oxygen to that big, thick ventricle. If it was pulmonary hypertension with some right heart failure, my first line pressor would probably be norepinephrine. And then if they were really, really bad, I would probably be leaning something more like starting something like milrinone even before induction with maybe some vasopressin. So it's an impossible question to answer unless you want to give me a ton more information. But the only thing that I would say is you start with knowing the pathology. The next step is knowing what the goals of that pathology are, what your goals are to keep that patient from dying. And then you think about your drugs and you figure out what will meet those goals. Find these patients harder to paralyze, not necessarily their longer cases, and sometimes the temperature shifts in the case. Remember, we said we were cooling them down and then heating them back up. Sometimes that can kind of chew through paralytics a little bit more, but not necessarily. Yeah, generally don't use Nimbex to paralyze, especially with Sugamidex. It's lovely. Usually, just commenting on this, extubated within 6 hours. Our goal is extubation between 2 and 4 hours. So these are fast track patients, and there are definitely some standards that are tied to that as far as what percentage of patients you're able to fast track and extubate quickly. But our goal is almost always to be less than 4 hours. We generally do not, yeah, as Ria said, so we generally do not reverse our patients. We're a little bit careful with our paralytic towards the end of the case. We don't push a big dose right as we're leaving the room. And in that 2 to 4 hours, the drug wears off. The ICU is much, 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 much more conservative than anesthesia as far as extubation. The patients are completely awake. They run through breathing tests, like spontaneous breathing trials. So they are very careful to not extubate when there's still residual paralytic. And our reintubation rate is, I think, less than 1% in our ICU. So they do a pretty good job with that. I would argue they probably wait a little bit too long on some if your reintubation rate is that low, but we can argue about that later. There are some places where we will extubate in the room. I have never worked in one of those places. If you have a good ICU that is extubating patients in that 2 to 4 hour, I don't see the purpose necessarily of extubating in the room. If you have an ICU that is taking 8 hours to extubate simple cabbages, then you might have to kind of take matters into your own hands and extubate in the room. The problem with extubating in the room is that there are a certain percentage of patients from cardiac surgery that are just going to bleed and need to come back emergently to the OR. And the last thing I want to do in one of those patients, that usually happens within the first 2 to 4 hours. And the absolute last thing I want to do is to have to deal with their airway when that's happening. I want them to already be intubated. We can go in, we can fix the problem. But then again, we have an ICU that is pretty proactive about extubating.
We
Yeah,
also did a lot of off-pump cabbages as well, which is not something that we talked about during this webinar. But for people who are not familiar, you can do a cabbage without putting somebody on a bypass machine. I feel like that trend has kind of like waxed and waned. It got like super popular, and then people kind of stopped doing it. But so those patients, we tend to extubate more of those patients.
So off-pump cabbages became very popular because it sounds great, right? We can do the surgery without putting a patient on the bypass machine, how could this be bad? And then they did, I think, three big studies, 10, 20,000 people. And they found out that it was much, much worse for patients to do it off pump than on pump. It's worse in a different way, but there's a lot more intraoperative hypotension and
Yes.
events like that. So we still have a surgeon that where I work that does some off pump stuff. I did one today. And he's very good at them, but overall, it
Or
generally has,
harder cases. Yeah.
yeah, much harder for anesthesia as well because the
Yeah.
heart is getting kind of lifted in every direction depending on where the anastomosis are. So the heart will be up on its side and the patient will be on epi and you'll be pushing doses of vasopressor because the blood pressure so low, and then they'll put the heart down and all those vasopressors will kind of hit and the pressure will go up and you're giving nitro to get the pressure
Mhm.
back down. So it's a very labile course, and you do a couple of them and you're like, yeah, I can kind of see how this maybe not isn't the best for the patient. But honestly, a lot of the reason it gained favor is because it was faster and you could do 3 hearts a day,
Right.
not having to go on pump. And so as soon as that data started coming out, it definitely we're definitely in the waning side of those.
Hmm.
Um, Pacemaker, yes, I do. I take care of the pacemaker during the case and afterwards. Um, so I won't get into this one too far because I could literally talk about this one question for an hour. Why milrinone before induction in a right heart failure patient? But this is one of those cases where if I'm going to put somebody to sleep, I'm understanding that any drug that I give them is going to lower their blood pressure just because it's going to remove their sympathetic tone. And right heart failure scares me much, much more than left heart failure because the right ventricle is much, much more difficult to manage than the left ventricle. It's much, much finickier. So on patients like that, knowing that I'm going to set this patient up for failure with some drugs that are going to lower their blood pressure, and that will lower their right heart contractility, I will start a milrinone is a relatively selective right. It's good for the left heart, but it has a couple little things about it that make it even better for the right heart. I'll start a little bit of milrinone before induction to get their right heart squeezing better and their pulmonary arteries to dilate to offload their right ventricle, while at the same time maybe using some vasopressin, which will give me peripheral vasoconstriction without pulmonary vasoconstriction. So my right heart is squeezing better. It has lower afterload, so it can cross over to the left ventricle, but I'm still back feeding the right ventricle with perfusion because of that vasopressin. So that's kind of setting me up the best circumstances possible for not having a patient dying during induction, which really, really, really bad right heart failure patients absolutely can. I hope that made sense. Yes, ICU hates extubating hearts in the OR. That is 100%. We do not use inhaled nitric. We use Flolan, epoprostenol. So that is what we use as our inhaled pulmonary vasodilator. We do not get a ton of it. Usually we can manage those cases with um, milrinone or something like that, but absolutely we do have cases that come out on Flolan. Yep, absolutely. Off pump, older surgeons. So off pump cabbages was like 90s, was really,
Hmm.
really hot. And so everyone that was getting out of training and doing it there, they all think they're really, really great at them, and all the newer surgeons don't. I think we talked about that reversal. Yeah, good point is sometimes patients can't tolerate on pump, whether their aorta is so calcified that you literally can't get a clamp on it, or they're on dialysis and they don't want to have to take a hit to the kidney perfusion. Sometimes it's almost by necessity that that they do off pump cabbages.
Do you do a lot of robots where you're at, Alex?
No, no. We do a little bit. We do more robotic, thoracic, like thymectomies and things like that. But generally not a lot of robots.
Mm.
One surgeon does some robotic Lima takedown stuff, but I think that has swung back in the opposite direction with the advent of more interventional cath lab procedures like
Mm.
mitral clips and things like that. The healthier or more suitable patients are taken from that robot cohort and moved to that interventional cohort. So the only people left in that, open sternotomy area are just the sicker people.
Mm.
LVAD procedures. As Ria said, we are, as part of atomic anesthesia, we do have a big cardiac anesthesia kind of course set up, and there is a specific section on LVAD procedures, but LVAD procedures are all about getting the patient to sleep safely. Once the actual procedure is done, they're usually better off because they now have a little bit of support. But by definition, the patients that need an LVAD are really, really, really sick. So it's the induction and the getting access to the heart are the worst parts. These are all people that have EFs of 10%, things like that. So knowing their pathology, whether it's ischemic versus non-ischemic, and thinking ahead towards what your induction drugs are and how to kind of offset the things that you're doing is really, really important in those cases. PDCV, that is something that I would never do. I'm very glad that you do it, though. Any other questions?
That was awesome. So much information. I hope that everybody got a lot out of that talk. And that's just really the tip of the iceberg for this like pretty complicated field that you're in. So thank you so much for being a guest for the webinars and for just everything that you do for Atomic. Alex is just such a great collaborator and a great expert in this topic. You guys have definitely given me a lot of suggestions in the chat as to which webinars you want to see next. Somebody suggested some regional webinars, and even for Becky to give a PD CV webinar as well. So thank you, everyone. You definitely know how to reach me, Ria at atomicanesthesia.com. Alex, if people want to reach you, what contact information, or how can people reach you?
Email's great. GORMAN82 at hotmail.com, Gorman82. And if you don't remember that, I'll actually just type it in the chat. How about that?
I gotcha.
Okay.
Awesome. Thank you.
And very happy to chat with anybody. No problem. Send me an email.
Yeah. Just want to give everybody an update as far as the platform. So, as you all know, we are building and releasing our platform this summer. Sachi and I actually found a really great software developing team that we're meeting with twice a week now to build out all of the content. But we are actually finding this to be a little bit more difficult than we thought because there's a lot of features that we think would be pretty cool. But for a first version or first edition, we can't build all of them, right? So we want to definitely hear from you and get your feedback as to what features you want to see. If there are any tools that you currently use in CRNA school, like we had talked about Notability or Anki flashcards, or anything that you maybe don't like about Apex that you would like to see improved with those types of board study platforms or educational platforms, please reach out to us and let us know if you would like to be a part of our beta group. We have a beta group of about 12 to 13 people right now that do a lot of testing for us, and they get all of our content, like our farm course, our drug badges, and then pro access to the platform for free as being a part of the beta group. So if that is something that's interesting to you and you want to help us build this platform, definitely reach out to us, and we'd love to have you as a part of our team. So let us know. You can email me, Ria at atomicanesthesia.com. Yeah. Um, yeah, please, the beta group. So, if you're already using Apex, the goal of this platform, and I'm not shy to say it, is to replace Apex. That is our main goal, is to create a platform that is better than Apex, that has community features, that has AI features, and allows you to basically, if you're using many, many tools right now, to basically be an all-in-one hub for everything that you do for CRNA school. So we're planning on doing Anki Deck integrations. We have a massive question bank. Alex does our cardiac content. Becky does our peds content. And then MTSA's Pain Fellowship program just reached out to Atomic for a partnership and collaboration to do all of our regional and ultrasound work. So we have lots and lots of great partners. So yeah, let me know if you want to be part of the beta group. Shoot me an email, ria@atomicanesthesia.com. Love to hear from all you. And thank you so much. Have a great night. We'll see you at the next webinar.
Thank you.
You're welcome. And thank you, Alex. That was awesome. Have a good night, everyone.
Thank you. Sorry for that voice.
Please get something better than Apex. I think there's an error in Apex about the airway fires. Well, I'm sure there are going to be errors in our platform for a while until we get it all fixed out, sorted out. All right. Good night, everyone.